Hello, everyone, and a warm welcome to today's edition of Podcast. Today is Tuesday, June 7th, 2022. I'm Rifat Mannan in California, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are very delighted to welcome Dr. Jacqueline Watkins, who is an assistant professor of pathology at Harvard Medical School, and she is also an attending pathologist at Mass General Hospital. So today she is going to deliver a talk on placental pathology, and the title of her talk is Placental Pathology and COVID-19. And as always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and we will pass them on to Dr. Watkins towards the end of the session. And just to let you know that this session will have CME credits, so you will be able to get CME credits through City of Hope, and the code will be shared to you towards the end of the session. So let me share the screen so that just to give a quick instruction about how to get the code. 1 second. So if you have not created an account, you should create an account at the City of Hope CME system. And I will share the registration or email website on the chat boxes of both Facebook and YouTube. And if you're an international participant, then you can email the code to this email address for City of Hope. And if you are participating from United States, you have the option to text the code to this phone number, or you can also email to this cme@cityofcoas.org. And I would repeat that the code will be provided towards the end of the session, so stay tuned for that. And with that, I would pass over to Dr. Watkins. So over to you now. Thank you so much for joining us today.
Thank you so much for having me. Let me just share my screen. All right, so the topic of today's talk will be the road to defining SARS-CoV-2 placentitis. And just by way of sort of introducing the topic, I first have nothing to disclose. And we'll go through a sort of an introduction and discuss the early studies on SARS-CoV-2 in maternal infection and placentas, and then go through the process of how SARS-CoV-2 placentitis was actually defined. We'll discuss at length a bit about the stillbirth history in association with SARS-CoV-2 placentitis, and then also how perhaps we can explain some of the stillbirth or infection of the placenta through a combination of viremia and how vaccination may actually prevent that. And then I'll provide some conclusions and some lingering questions, some that will be answered, I suspect, in the near future by additional research, but other ones that may be years out from actually knowing the answers to. So just by way of introduction, we actually had experience with coronaviruses prior to the SARS-CoV-2 pandemic. And specifically, there were two coronavirus outbreaks that happened sort of in the last couple of decades that were associated with adverse obstetrical outcomes. And the first, of course, was in 2003 when SARS, or severe acute respiratory syndrome coronavirus, came on the scene. And at the time, these outbreaks weren't enormous in number, nowhere near the level of disease that we're seeing with COVID-19, but there were large enough cohorts to examine a few pregnant patients. And in one particular study from 2003 that looked at 12 cases of pregnant women with SARS, the results were that 4 ended in first trimester spontaneous abortions, 4 resulted in preterm deliveries. There were 2 examples of IUGR cases and 3 maternal deaths. So at minimum, we knew that there were poor both maternal and perinatal outcomes in at least a subset of women infected by SARS. And then in 2012, MERS-CoV, which is Middle East Respiratory Syndrome coronavirus, came on the scene. And in one study that was done in Saudi Arabia, they had 5 cases in pregnant women that resulted in 2 maternal deaths and 2 perinatal deaths. So again, some evidence that we have poor both neonatal or intrauterine outcomes for a fetus, as well as for women who are infected by coronaviruses while pregnant. And then, of course, as we're all unfortunately terribly familiar at this time, in December of 2019, a new coronavirus came on the scene, which was SARS acute respiratory syndrome coronavirus 2, or SARS-CoV-2. And of course, because of our prior experience, as well as experience with any new virus and how it might affect mothers and fetuses, there was growing concern and big questions that needed to be answered. First, of course, could there be intrauterine transmission from mother to fetus? Was there a degree of maternal morbidity or mortality that we needed to be concerned about? And what about fetal or neonatal mortality and morbidity? So this brought us to the very early studies, early in the pandemic, that started to look at SARS-CoV-2's effects on obstetrical outcomes and, of course, pathologic obstetrical outcomes. And in the very early days of the pandemic, we thought congenital infection was exceptionally rare. And in fact, it still is extremely rare. But we thought it was so rare at that time that nobody really expected necessarily that we were going to find placental evidence of direct infection by disease, because there had been no reports really early on that suggested that congenital infection was a huge burden. Additionally, early in the pandemic, we didn't have great methodology to identify viral particles within tissues. So at first, of course, these techniques needed to be developed, but then secondly, the IHC for SARS-CoV-2 as well as ISH for SARS-CoV-2 wasn't widespread. So it was really at limited institutions. And that, of course, hindered early methodologies in a lot of papers as well. And logistically then, in the absence of having these methods be widespread, and of course thinking congenital infection was rare, the first and perhaps the easiest pathologic question to answer was, is maternal SARS-CoV-2 associated with placental changes? And thinking that direct infection of placenta was likely rare given the very low volume of congenital infection, early studies, I believe, mostly hypothesized that any changes to the placenta were going to be a consequence of maternal symptoms. So specifically, if a mother was in the ICU or herself hypoxic, we should see evidence of hypoxic changes in the fetus. So we can start to think about things like, was meconium, higher in babies who were delivered at term to an infected mother? Do we see evidence of maternal vascular malperfusion, knowing that SARS-CoV-2 is associated with certain thrombi or hypercoagulable states? And additionally, we didn't really expect necessarily to see a characteristic pathology for SARS-CoV-2 infection. But of course, that was in the back of the minds of these early studies, was if there was evidence that SARS-CoV-2 could directly infect the placenta, there may be sort of a triad or, a pathognomonic histopathology that would allow us to diagnose that. So that brings us to sort of our early studies. And early on, basically everyone was looking at all comers, so all moms who had SARS-CoV-2, sometimes at time of delivery, other times at any point in pregnancy. And they were looking at what those placentas looked like. So basically, if mom was infected, her placenta ended up in the cohort. And in general, we had a bunch of findings that were not terribly specific and at times significant, and at other times results that were completely contradictory. But in general, there were very early studies that suggested that there were increased features of maternal vascular malperfusion in mothers with SARS-CoV-2, that there were increased evidence of fetal vascular malperfusion in the placentas for mothers with SARS-CoV-2. And then sometimes there was also some references to inflammatory lesions being present in those placentas, things like velitis, chorioamnionitis, or chronic histiocytic intervalocities. And of course, some of these studies showed that there were no significant or specific pathologic changes in placentas from moms with SARS-CoV-2. Of course, as I already mentioned, there were limitations in these studies at the beginning. First, there was no way to necessarily confirm that SARS-CoV-2 had actually infected the placenta. And there was very limited evidence of placental infection, at least from the clinical perspective, because not all of the babies born to these particular mothers were infected. So we didn't even have evidence of congenital transmission in a lot of these studies. So the combination of those two things really limited our search sort of for histopathologic pathognomonic features of SARS-CoV-2 placentitis. And these results ultimately, didn't tell us anything terribly specific, and again, contradicted one another. But over time, as we got a better grasp of what was going on in the neonatal side of SARS-CoV-2, we started to get a better understanding of neonatal infections and larger numbers of neonatal infections. And ultimately, a statistic drawn up in 2020 suggested that about 70% of neonatal SARS-CoV-2 infections were due to environmental exposures. And this is back in the days of the pandemic, where after a baby was born to a mother with SARS-CoV-2, the mother was often separated from the infant to prevent this transmission. And so at least in some of these cases, they could be confident that in those cases where the baby was split from the mother and or the baby tested positive within 24 hours, that there still were some vertical transmission cases as well. And it was estimated again in 2020 that 30% of cases were vertical transmission. And a fraction of these, of course, that vertical transmission can mean two things, basically. You can have congenital infection, meaning something passed directly to the baby from the mom during intraplacental and intrauterine times, or that it can pass from mom to baby during actual delivery. And ultimately it was estimated that of all these vertical transmission cases, 5.7 to 10.6% of cases were truly congenital in the sense of transplacental infection. And again, this was a rough estimation because we didn't have complete information at this time and variably sized cohorts. But again, proved, or suggested anyway, I should say, that transplacental infection was happening at some non-nominal rate. And then came a major study that showed that the placenta could be directly infected by SARS-CoV-2. And this was done first through electron microscopy. And this is just a picture from this paper by Algaroba et al. Back in 2020 that actually showed infection. And you can see the viral particles here in this photo, infection by the virus of syncytial trophoblasts. And after that study came out, of course, there was now a new sort of reinvigoration of this idea that we should find some pathognomonic histopathology for SARS-CoV-2 infection of the placenta. And that became easier to actually accomplish because simultaneously, people were working on developing more widespread and easily usable ways of identifying SARS-CoV-2 placenta or infection of tissues. And specifically, RNA-ish and IHC for SARS-CoV-2 was developed and were shown to be very reliable initially in lung tissue sections with a sensitivity of 86.7 and 85.7% respectively. So these two techniques came on the scene and really changed our ability to then look at placental infection. So with these new techniques, the question of transplacental transmission could be definitively answered, not just implied through clinical outcomes. And specifically, to say that something is caused by transplacental transmission, you need to first prove that mom and baby end up being infected, with the infant being infected less than 24 hours, usually after delivery. But more specifically, you need to actually find that the virus can infect the placenta itself. And examples of viruses that do this that we've known about for a long period of time, of course, are CMV and HSV. And then once you could actually establish that the virus infected the placenta and ultimately build up a cohort of infected placentas, so not just infected moms, but truly infected tissue at that point, you could start to look for specific histopathologic features. And the example from other viruses would be that, over time we found that CMV caused chronic velitis with an element also frequently of intervalocities, and typically there were plasma cells present within the villi. And those plasma cells in the setting of the chronic velitis were really pathognomonic of CMV and HSV infections, for example. So the first study that really looked at what was assumed to be placental infection directly had to look at maternal and fetal dyads of infected pairs. So basically, Schwartz and Moretti reviewed placentas from infected mom-baby pairs, and they found three characteristic histopathologic findings in these cases. And the first was a chronic histiocytic intervalocities. Secondly was syncytial Trophoblast Necrosis, two entities that I'll come back to in a few slides. And then they proved that all of these placentas were positive for SARS-CoV-2 by ISH or IHC. And at the end of this study, which this study was largely out there to prove that transplacental infection could occur, they noted that trophoblast necrosis and the chronic histiocytic intervalocities, or CHI, were risk factors for transplacental maternal to fetal transmission. So basically, the destruction they were seeing of the placenta was what was allowing the SARS-CoV-2 virus to enter the villi and ultimately enter the fetal bloodstream. Now, simultaneously at MGH, we were starting to see in fall of 2021 an increase in in-house cases and referral cases of markedly atypical placentas from maternally infected cases. And simultaneously, we were developing in-house methods of doing RNA-ish for SARS-CoV-2 and ultimately had that online by 2020. And we were able to identify a cohort of SARS-CoV-2 infected placentas, a total of 7 cases, relatively early in the pandemic. And we asked ourselves the question, just like Schwartz and Moretti had sort of outlined previously, could we really use this cohort to define SARS-CoV-2 placentitis? And when we examined our cases, we started with the gross features because the gross features are pretty significant in SARS-CoV-2 placentitis. So all cases in our cohort showed a variegated placental parenchyma with a marked, typically diffuse fibrin deposition. So if you look at these pictures here, the one on the upper right is a picture from a fixed placenta, and most COVID-infected cases are fixed before grossing. So it's good to see this both in fixed specimen and a fresh specimen seen below, because the appearance can be somewhat different. But when the tissue is fixed, you're able to see the fibrin deposition being very marked and very tan white in appearance. I often tell my residents it sort of looks like marbled steak to some extent. And it certainly mimics what we see with massive Perivilus fibrin deposition, which is a separate entity from SARS-CoV-2 placentitis, which I'll mention more in a few slides. And in the fresh example, you can again see that sort of marbling of the fibrin. And the fibrin, again, in most cases was very diffusely found. So in many cases, even greater than 90% of the placenta looked like this. And then in our study, we started to find very characteristic features under the microscope, but we also only included cases that showed positivity for SARS-CoV-2 RNA-ish, so proving that there was actually direct infection of the placenta by coronavirus. And the specific histologic triad that we came up with was the presence of histiocytic, occasionally neutrophilic intervalocities, perivilus fibrin deposition, and trophoblast necrosis. So first, let's examine histiocytic intervalocities. So what we're looking for basically are monocytes present between the villi, often filling, again, a significant proportion of the placenta. And these can be highlighted by CD68 staining when there's any doubt of what their nature is. And PU.1 would also work. We happen to use CD68 in our study. And when we looked at the degree of histiocytic intervalocities, it was often approaching or equivalent to what we would make of a non-infectious case diagnosis of chronic histiocytic intervalocitis. So chronic histiocytic intervalocitis, just to review for a moment, is a rare, often recurrent placental lesion, and the recurrence rate is as high as 25 to 100%. And it's defined by the presence of maternal macrophages infiltrating the intervillous space. And in these cases of chronic histiocytic intervalocitis, there is a very high risk of fetal growth restriction, miscarriage, stillbirth, and neonatal death. And there's often also association with increased perivilus fibrin deposition. And of note, in the non-coronavirus setting, these particular features tend to occur or have an association with autoimmunity in mom. So I bring this up because the findings that we were seeing were so significant in terms of the volume of disease that we suspected ultimately, and this sort of foreshadowed what's going to come later in the talk, that the outcomes were going to be similar to what we see with chronic histiocytic intervalocitis. So we started to become worried that things like stillbirth, IUGR, and miscarriage were going to be increasing during the pandemic. The next major feature of SARS-CoV-2 placentitis is perivilus fibrin deposition. And again, this finding in our cohort tended to be quite diffuse and reflect what was seen grossly. And what we're looking for basically is a ton of fibrin deposition within the intervillous space, often concentrically around the villi. And massive perivilus fibrin deposition on its own, meaning in a non-infectious state, is its own unique, rare entity within the placental pathology community. And it has, just like chronic histiocytic intervalocitis, a risk of recurrence. And basically, to make the the diagnosis of massive perivilus fibrin deposition, again, in the non-infectious state, you need greater than 25% of the placenta to be infected. And this is a gross measurement of 25%. And just like chronic histiocytic intervalocitis, massive perivilus fibrin deposition is associated with intrauterine growth restriction, preterm delivery, fetal or neonatal death, neurologic impairment. And all of this is thought to be due to decreased gas exchange from the maternal blood to the fetal blood due to basically obstruction by fibrin. And in the non-infectious cases, this is associated with antiphospholipid antibody syndrome. So again, an autoimmune element. But again, seeing these findings being so significant in SARS-CoV-2, we were worried that we would eventually start seeing the same outcomes that one sees with massive perivilus fibrin deposition in SARS-CoV-2 placentitis cases. And here's just another picture of massive perivilus fibrin deposition as seen in the coronavirus cases. And you can see a little bit of the monocytes in the background, but you start to see the concentric placement of the fibrin around the villi. And then the last major feature that we see with SARS-CoV-2 placentitis is trophoblast necrosis. And so in this picture, we actually see all three features pretty nicely. We have the histiocytes within the intervalous space, we have the fibrin deposition, and then we also start to see sort of smudgy syncytial trophoblast in the background and basically early evidence of necrosis of the syncytial trophoblast and cytotrophoblasts around the villi. We also had a few additional findings in our paper. First were that the features, as I've already mentioned, were quite diffuse, being greater than 90% of placental parenchyma involvement by gross. No infants in our particular cohort who were tested had congenital SARS-CoV-2. So they were negative by PCR. And what that meant was that you could have SARS-CoV-2 placentitis, but not congenital infection. So in some cases, be it time, other hypotheses regarding sort of immune state in other aspects, we're somehow mitigating against the neonate being infected. But also what's important in that finding is that you could have such massive tissue destruction of the placenta independent of the fetus or the neonate being infected. And therefore, when we started to look at bad outcomes, we knew that the bad outcomes in neonates didn't have to be related to SARS-CoV-2 actually infecting the baby, and instead could be related just to how significantly the placenta was infected. And in fact, in one of our cases that we had used of the 7, the pregnancy ended in stillbirth at 33 weeks, and that fetus in particular was not SARS-CoV-2 positive. So again, alluding to things that we'd find in the future once stillbirth became a bigger entity and a bigger concern. And the last significant finding within our study was that C4d deposition was noted in 5 of our 6 placentas. And this made us, hypothesize basically that complement system activation had a role in destruction and transmission of SARS-CoV-2 from mom to baby, but also a role in damaging the placenta. So how would that work? And just before I get into it here again is the classic features of SARS-CoV-2 placentitis up on the left and the example of our C4d deposition on the surface of the villi. So what we hypothesized was basically that the virus would infect the trophoblast, causing complement activation and C4d deposition. And that would lead to a local upregulation of cytokines. And the cytokines are what draw in the monocytes. So it's the reason basically that you end up with a histiocytic infiltrate. And then at the same time, the cytokines cause a procoagulant environment, which leads to fibrin deposition. And ultimately, we think the last step sort of in destruction right before transmission from mom to baby is trophoblast necrosis, which is probably a result of both monocyte adhesion and fibrin deposition, basically as the villi start to die off because they're being choked out of their oxygen and nutrient supply. And ultimately, again, these features come together to cause destruction and ultimate entry of the virus from mom's blood into fetal blood circulation and thus transplacental transmission. Now, as I mentioned, one of the things that we started to get paranoid about was that stillbirth was going to be on the rise, given that these findings outside of the infectious state are associated with stillbirth. And early meta-analyses through July of 2020 did not show any significant increase in intrauterine fetal demises or neonatal death in the early months of the pandemic. So these are sort of pre-alpha and delta waves of the pandemic. But then in spring of 2021, the alpha wave came to Europe. And there was a very alarming report, sort of like a news report coming out of Ireland, that 7 cases of fetal death had been noted, with 6 of them being stillbirths and 1 death being the second trimester miscarriage. And all of these placentas in these cases were confirmed to be positive for SARS-CoV-2 by IHC. And they all demonstrated the histologic triad of SARS-CoV-2 placentitis. And there was basically a concern now that there was something about the alpha variant, which was also known as B117, that was doing something to the placenta so massively or somehow causing stillbirth that we hadn't yet seen in the coronavirus pandemic. And most of their cases, just to note, because we'll get into timing of infection a little bit later on, most of these infections happened between 0 and 21 days of delivery. So it seemed to be something about acute infection in mom was leading to stillbirths or the second trimester miscarriage. And then by November of 2021, in the United States, we were in the middle of the Delta wave, and the CDC issued a notification that the risk of stillbirth was 2 times higher in pregnant women with COVID-19 compared to those without COVID-19. And the magnitude of this association was particularly high when it was restricted to just the Delta variant compared to the pre-Delta variant. So we were starting to see issues with stillbirth, particularly in the Delta wave, as we were moving through the COVID-19 pandemic in the US. Now at MGH in fall 2021, we were having the same sort of anecdotal concerns as we had seen in Ireland, and then also what the CDC had issued, which was in-house. We were seeing an alarming increase in intrauterine fetal demise associated with SARS-CoV-2 infection and placental damage. And we are also fortunate here that one of my colleagues, Dr. Drusilla Roberts, gets a significant number of placenta seen in consultation. So she was getting to see many cases from throughout the country being sent here for confirmatory in situ hybridization and evaluation for SARS-CoV-2 placentitis. So we were starting to amass really a nice cohort of cases, and I use the word nice from a path perspective. Certainly it was not nice to see this level of IUFD and concern for stillbirth, but we were able to amass a large enough case cohort to try to start to understand why was suddenly SARS-CoV-2 infection causing stillbirths. Was there something different about the Delta wave and the Alpha wave? Was there something different about the SARS-CoV-2 placentitis in the Delta and Alpha wave? And so we had to step back for a minute and think about how sort of this infection was happening within the placenta and why we're seeing stillbirths. And to think about that, the first thing that I think most placental pathologists would consider is basically a SARS-CoV-2 acting like a torch infection. So if we step back for a moment to sort of the pathophysiology that we hypothesize for SARS-CoV-2 placentitis, we end up with the monocyte adhesion, fiber deposition, and the trophoblast necrosis with the transplacental transmission. And in the vast, vast majority of torch infections, it's actually after transplacental transmission to the fetus. So the fetus gets infected and ultimately has complications with their own organs and own environment that causes fetal death. So it's fetal death by direct fetal infection. But we already knew from at least our in-house stillbirth, as well as many, many case reports were coming out at this point in time, that there were stillbirths without evidence of infection of the fetus. So we knew that that couldn't be the explanation. So a torch infection model didn't really make sense for SARS-CoV-2. So then we started to wonder, and a lot of the community of OB pathologists at this point in time were starting to suggest that monocyte adhesion plus fibrin deposition were somehow leading to massive placental insufficiency. And so SARS-CoV-2 was really unique in essentially killing babies by causing massive placental damage rather than actually causing damage to the neonatal tissue directly. So how does this happen, and how does this even cause fetal loss? So as we're all well aware, the placenta is largely responsible for mediating oxygen and nutrient transfer to the fetus. And by largely responsible, it's entirely responsible. That's the whole job of the placenta. And as, again, we all know, maternal blood fills the intervalous spaces from these spiral arteries of the uterus. And basically, there's an oxygen gradient that should exist between the maternal blood and the fetal blood that's within the capillaries of the villi. That's partially flow dependent. So basically, you need to have constant movement of maternal blood with a good high oxygen content and nutrient content going through the placenta to cause the oxygen gradient or nutrient gradient to be such that the oxygen and nutrients are driven from mom into and across the barrier of the villi into the fetal circulation. But in order to get this flow, this free flow that allows for oxygenation of the placenta, you need to have an unobstructed intervalous space and intact chorionic villi, because otherwise you basically can't do oxygenation of the fetal blood and you can't get nutrients across the placenta. Well, of course, now knowing the three major features of SARS-CoV-2 placentitis, we were able to see that there was a clearly reduced free flow of maternal blood due to physical obstruction. So the presence of fibrin and now a ton of histiocytes within the intervalous space was not allowing for mom's blood to flow freely to the placenta. And then, of course, the villi couldn't really do their job anymore because they're encased entirely in fibrin. So they're being essentially choked off from the oxygen gradient. And then there was actually trophoblast necrosis. So now even the trophoblasts that were there as a barrier and helped with this, transmembrane perfusion weren't working anymore. And ultimately, you would end up with massive fetal hypoxia due to placental insufficiency and, in severe cases, stillbirth. And I really like this quote from David Schwartz, who wrote a really nice review in 2022 in Viruses regarding SARS-CoV-2 placentitis. And he said in his paper that there has not been a viral infection of humans ever reported that consistently and characteristically produces placental insufficiency to the extent of causing intrauterine fetal demise or perinatal death. And this, of course, is written with the next line being an exception, of course, SARS-CoV-2 placentitis. And so it's kind of amazing, but SARS-CoV-2, again, just to hit it home, it's not about infecting the baby that leads to stillbirth or miscarriage, and much more to do with just massive destruction of the placenta. So the next few questions came from sort of these models and these ideas that were circulating in the OB pathology community. And the next natural question was, why do only some SARS-CoV-2 placentitis cases result in stillbirth? And of course, another question, which we'll get to in a few slides, was also, why is there so much SARS-CoV-2 around and so many infected, pregnant women, but why do we see so little SARS-CoV-2 placentitis? So the outcomes are very rare. But we were getting into large enough cohorts to look at what might be different about SARS-CoV-2 placentitis that ended in a live birth versus SARS-CoV-2 placentitis that ended in miscarriage or stillbirth. And there are several hypotheses, many of which have still not been entirely figured out. But some of the hypotheses behind the stillbirths were extent of placental involvement. Now, as I mentioned, from at least the MGH cases, placental involvement tended to be greater than 90%, even in cases that went to term or ended in live birth. So it's unclear how much extent of placental involvement is critical, but I suspect you need massive involvement to end up with stillbirth because all stillbirths have shown massive involvement. Another hypothesis behind this is, are there additional stressors on the maternal to fetal blood flow that basically, are the straw that broke the camel's back kind of situation? So, the placental insufficiency caused by SARS-CoV-2 was exacerbated by one additional change to the placenta that then resulted in stillbirth. And we have some evidence that this might be the case. And then there has been some suggestion that timing of infection relative to delivery may be needed, though a lot of these studies need quite a bit more data to be fully fleshed out and really explain how timing might be relevant. But coming back to the second point, which were the additional stressors on the maternal to fetal blood flow, I'm just going to come to another paper written by our group that had to do with the MGH experience with stillbirth during the SARS-CoV-2, particularly the Delta wave of SARS-CoV-2. And our group started to note that there were some gross findings that had been consistently noted in cases of fetal demise. And so looking at the placenta, this is from a case of fetal demise, we started to sort of reread the path reports, either the ones that were received in consultation or in-house ones, and started to notice that some key phrases were coming up. And things like multicystic areas filled with blood clot were noted. There were multiple hemorrhagic areas within cystic structures. There was a dense pale fibrotic, parenchyma admixed with cystic spaces filled with blood. So again, I mentioned time and time again of these cyst-like spaces filled with blood or hemorrhagic areas. And this is a really beautiful example of one of the cases that has these multiple hemorrhagic foci sort of within, again, vaguely cystic structures throughout the placental parenchyma. And of course, in the background, you can simultaneously see, and this is of course a fixed placenta again, that tan white change consistent with the massive Perivilus fibrin deposition. Here's another example from a fresh placenta that has, again, these large sort of lakes of blood within these cystic spaces. They don't look grossly lamellated or really jelly-like the way that an intervillous thrombus looks, and so look a little bit more fresh. And here again is a fixed example with, again, cystic spaces filled with blood, and here are a few more here as well, very recent looking hemorrhage. And under the microscope, in these stillbirth cases that we had started to amass, we first, of course, confirmed that there was, infection by SARS-CoV-2 via ISH of the placenta directly. But then we also looked at for the triad, and time again, we would find the massive Perivilus fibrin deposition, the histiocytes within the intervillous spaces, and of course, necrosis of the syncytial trophoblasts themselves. And the basic under the scope appearance of these hemorrhages were just what they looked like grossly. So you'd see these large, fresh hemorrhagic spaces, somewhat rounded in appearance at time, with very minimal to no lamination or otherwise very minimal organization, usually at the periphery. And basically, Dr. Drusilla Roberts and Ann Hun, who is one of our trainees who wrote this beautiful paper, came up with the term thrombohematoma to denote these massive maternal lakes of blood within the placenta. And there, of course, is a question, I think naturally, of what's the difference between a thrombohematoma and an intervillous thrombus? Well, thrombohematomas tend to be more round and, again, less laminated than what we see in an intervillous thrombus. And they tend to look like, if you've ever seen an infarction hematoma, they tend to look like the central area of hemorrhage within an infarction hematoma. And our group was left with two hypotheses for these formations. So we first thought maybe it was the vasculosyncytial membranes losing their integrity through necrosis that led to a leakage of fetal blood into the maternal space. That's certainly a possibility. We didn't see a ton of nucleated red blood cells in these hemorrhages, so it wasn't definitive that that was what was going on, but that's one hypothesis. And the other option is that these represent lakes of maternal blood that have basically been trapped into pools because there's so much fibrin around that's sort of keeping blood from flowing freely, and you end up with these at times almost organizing or early organizing clots after the fibrin deposition gets massive. And the reason I mentioned these as sort of a potential straw that breaks the camel's back is that when we looked at 47 cases of SARS-CoV-2 placentitis that we had amassed between 2020 and 2021, we found that 29 of 47 cases had these intraparenchymal thrombohematomas. But what was really interesting is that they were very, very common amongst specifically the stillbirth cases. So we had looked at SARS-CoV-2 placentitis in this study that had ended both in live birth and stillbirth. And 21 of 29 of our stillbirths, or 72%, showed these intraparenchymal thrombohematomas. And then interestingly, of 18 cases without thrombohematomas, 17 were live births. So in general, cases that didn't have thrombohematomas tended to do better. And then in all of our cases, infection was very recent, so within 14 days of delivery in 88%. And importantly, all of our cases were unvaccinated at the time of infection. So we were left wondering, this is a little bit of a chicken or egg question. Was the placentitis so bad as to cause the thrombohematomas? And then basically the thrombohematomas were sort of a result or an end effect that we are incidentally seeing in stillbirth, but had nothing to do with actual loss. And it was just that the placentitis was terrible. Or were thrombohematomas, again, sort of the tipping point and resulting in a worsening placental insufficiency and thus being actually the sign of ultimate demise or, the immediate sign right before demise. Now, there have been a few other studies that have now incorporated the terminology or looking for hemorrhages and their association with stillbirth. And one was done by Dubuque et al. In 2022. And they looked at 5 IUFDs, which again were all in unvaccinated moms. And in their cases, all of them had SARS-CoV-2 placentitis involving greater than 80% of the parenchyma of the placenta. And all were noted to have intervilus hemorrhage and subchorionic hematomas. So very similar to our cases, or many of our cases of stillbirth within our larger cohort. And then Schwartz et al. In 2022 looked at 64 intrauterine fetal demises and 4 neonatal deaths, and they found SARS-CoV-2 placentitis that was, again, denoted as severe because 77.7% of the parenchyma on average had been affected. And in their cases, 25 were noted by, per report, path reports to have intervilus thrombi, which again is not the same thing necessarily as a thrombohematoma, but this term was used interchangeably with hemorrhages in the paper, and ultimately hints again that thrombohematomas may have some role in demise. So what was really interesting from our study, and something that potentially might be of use in the future if we have to continue worrying about SARS-CoV-2 placentitis into the coming years, was that in the MGH cohort, 2 of our cases had ultrasounds documenting fetal demise. And at the time, the radiologist was actually able to see large maternal lakes with echogenic rins. And these areas, so here's our placenta, and you can see these cystic-like spaces with blood flow. These basically are radiographic evidence of what we were seeing histologically, both on gross, of course, and microscopic examination of these, quote, maternal lakes, which are equivalent to our path terminology of thrombohematoma. So another study by Soteru et al. In Diagnostics, of course, a radiology journal, looked at whether or not they could see other features of SARS-CoV-2 placentitis, but incorporated these maternal lakes and tried to look at how these might correlate with severity of maternal infection. So they had 20 cases of infected moms during the Delta wave, and importantly, their birth outcomes are unknown. So it's unclear if their findings yet correlated with stillbirth or poor neonatal outcomes. But they found that hospitalized patients with SARS-CoV-2 placentitis or presumptive SARS-CoV-2 placentitis frequently demonstrated these placental lakes and massive perivilus fibrin deposition, so greater than 30% of the placenta involved, as seen by ultrasound. And they came up with sort of a placental ultrasonographic scoring system for SARS-CoV-2 placentitis, looking again for the lakes that we had seen. Subchorionic edema was another feature that they were seeing commonly with SARS-CoV-2 placentitis, and fibrin deposits. And again, they found at least an association between the severity of maternal symptoms and the presence of these lakes. Not something that's necessarily been recapitulated or found again within the placental pathology literature. So now stepping back from just the question of why may some SARS-CoV-2 cases of placentitis result in stillbirth, let's now ask the question, why do not all cases of maternal SARS-CoV-2 infection cause placentitis? So in general, SARS-CoV-2 placentitis is very rare. Our best estimates are basically 1 to 5% of placentas from infected mothers demonstrate these changes. And overall, it's likely a combination of intraplacental immune response and maternal viremia that are responsible for the creation of SARS-CoV-2 placentitis. So first, just to speak to a little bit about intraplacental immune response. We know that placentas from mothers with SARS-CoV-2 demonstrate two transcriptomic changes. First, they have a very robust increase in natural killer cell expression of genes encoding cytotoxic proteins. And secondly, endothelial cells show upregulation of genes critical in an antiviral response. So in sum, both of these findings are preliminary evidence that there's an intraplacental antiviral response to maternal infection. And second from that, we also know, of course, that their variant or and/or maternal factors could be responsible for the robustness of this response. And one of the things that's been postulated to be responsible for why things look so bad during the Delta period is that the Delta strain had a spike P681R mutation that conferred S protein cleavability, with an S protein being a transmembrane serine protease that's expressed by the syncytial trophoblast. So it's possible that the newer variants actually have mechanisms to get around all of this, intraplacental immune response and are more effective at invading the syncytial trophoblast directly. Another possibility is that viremia might be a risk factor for SARS-CoV-2 placentitis. So in a very recent but small but very significant cohort of patients here, Shook et al., which is one of our MFM fellows here at MGH, looked at 2 intrauterine fetal demises and 1 case of severe fetal distress, all during the Delta wave and all known to be Delta variant infections, all with mild maternal disease and occurring in the 3rd trimester. And she found that maternal viremia was present in both stillbirth cases. High nasopharyngeal viral load and SARS-CoV-2 placentitis were present in all 3, and all patients had been unvaccinated. And the reason that this viremia finding is somewhat significant is that maternal viremia was not observed in the first wave of SARS-CoV-2. So in basically 2020, there had been a decently large study, I think it was 124 looked at by Edlow et al. In JAMA, that said that none of the mothers displayed viremia when their blood samples had been taken during the time of infection. And in general, only 1% of people with COVID-19 are thought to be viremic during their illness. So it's theoretically possible that those rare instances of maternal viremia, as seen in the stillbirth study, are the reason basically that SARS-CoV-2 can even get to the placenta. So you have maternal viremia leading to exposure to the placenta and ultimately infection of the syncytial trophoblast. And looking again a little bit at this viremia question, when we summarize sort of a lot of the stillbirth literature, so if we look at the 68 stillbirths from the Schwartz study, the 6 cases from Ireland, and a few other papers, including 5 cases from France, all of these mothers have been unvaccinated who have had stillbirths documented. And by unvaccinated, I'm including also women who had SARS-CoV-2 before at least 1 vaccine dose was administered. So we know that vaccines for SARS-CoV-2 are really good at producing an IgG response, and IgG responses are responsible for preventing viremia. And we know that in the cases of the BioNTech or Pfizer and Moderna vaccines, that this antibody response is really robust. So theoretically, vaccines should cause no or reduced viremia, which means you can't ever get basically coronavirus exposure to the placenta itself. And ultimately, vaccination should decrease SARS-CoV-2 placentitis and stillbirth risk. And we have at least clinical evidence that vaccination really is working really well to prevent SARS-CoV-2 placentitis as the middle mediating factor for poor outcomes. And we have this example from Scotland that in October 2021, which is basically the earliest that any maternal or any pregnant woman could have had 2 doses of vaccine, because the vaccine came out in December of 2020, they found that 32.3% of pregnant women were fully vaccinated, and that the extended perinatal mortality rate was 22.6 per 1,000 for women with COVID-19 diagnosis within 28 days of delivery, with a background sort of normal IUFD rate of 5.6 per 1,000 for non-COVID-related cases. And all fetal or neonatal death occurred in unvaccinated cases. And even when we look at maternal morbidity, then 77.4% of SARS-CoV-2 infections, 90% of SARS-CoV-2 infections requiring hospital admission, and 98% requiring ICU care all occurred in moms who were unvaccinated. So what we basically learned was that the stillbirth rate was much, much higher for women who were unvaccinated for SARS-CoV-2 during the Delta and Alpha waves, but were not higher for women who were vaccinated. We also know, because of course there's been a lot of vaccine skepticism, as we're all well aware, and particularly in the maternal community, there was critical need to also prove that the vaccine was safe for the placental fetal unit. And fortunately, a study done by Santos et al., led by Carlos Pereira over at the Brigham, did a really lovely job of showing that mRNA vaccines don't translate within the placenta. And what I mean by that is, of course, mRNA vaccines use translation of mRNA to create SARS-CoV-2 spike protein within whatever cells basically are injected. So this is usually muscle cells, and then antigen presenting cells will respond locally as well to the site of injection. But there was concern that if the mRNA particles that were injected could travel within the blood and end up in the placenta, that the placenta could actually synthesize its own spike proteins. And could that lead to basically induced placentitis or placental destruction as the body tried to recognize the spike protein as foreign? So what this group at the Brigham did was they looked at 48 pregnant women with 1 or 2 doses of mRNA vaccines, and 63% of those had had their latest dose within 15 days of delivery. So we're looking at placentas that are from moms who were typically very recently vaccinated. And all of these placentas were negative for the spike protein by SARS-CoV-2 immunohistochemistry. And that leads to the conclusion that immunization with mRNA vaccines does not lead to translation or accumulation of the spike protein in the placenta. And this really helps underscore the safety of mRNA vaccines, meaning that mRNA vaccines should not cause, really can theoretically never cause, SARS-CoV-2 placentitis or another autoimmune phenomenon within the placenta that would lead to stillbirth. So that brings me now to some lingering questions. So first, of course, is the simplest, which is that infected mothers probably need to be monitored more closely, particularly those infected in the 3rd trimester. And one of those questions is, can we now use ultrasound or perhaps viremia as ways to predict SARS-CoV-2 placentitis? And in those cases, follow those mothers very, very closely. Additionally, is there enough of a justification? I'm not sure we're there yet, but we're working towards it. Is there enough of a justification for thrombohematomas to be an indication for urgent delivery if the baby is old enough to be viable? And I think it's an interesting question, and one that really our radiology colleagues are probably going to have to sort out a little bit more working into the future. And then, of course, there's the big lingering question is, will future variants even cause SARS-CoV-2 placentitis? So far, at least at our institution, we have not experienced a case of Omicron-related SARS-CoV-2 placentitis. And granted, vaccination has been increasing in the population. It's certainly high adoption rate locally here. But it also makes you wonder if basically the strands are less capable of infecting the placenta. Something's going on here it's basically mitigating these effects. And so, should we brace ourselves for new cases of SARS-CoV-2 placentitis with future variants or not? We really don't know yet. And then lastly, and something that I've been thinking about that's not answerable yet, but will be answerable in the future, is should we be expecting long-term effects of SARS-CoV-2 placentitis the way we see long-term effects of massive Perivilus fibrin deposition and chronic histiocytic intervalocities? And by those long-term effects, I largely mean, are we going to see neurodevelopmental negative neurodevelopmental outcomes in children who are affected by SARS-CoV-2 placentitis who made it, who basically made it to term, but still with these, massively destroyed placentas. So just a few brief conclusions. We know that SARS-CoV-2 placentitis is rare. We estimate it's between 1% and 5% of placentas from infected mothers. It's defined by 3 main histopathologic features, which include histiocytic intervalocities, Perivilus fibrin deposition, with both of those reaching the levels of chronic histiocytic intervalocitis and massive perivilus fibrin deposition, as well as trophoblast necrosis. We know now that stillbirth may result from SARS-CoV-2, not due to infection of the fetus, but rather due to massive placental insufficiency. And in general, just as a recommendation moving forward, for those of you who may still be seeing or will see SARS-CoV-2 placentitis, it may be worth it, mostly for ongoing research, to include the presence or absence of thrombohematoma. So really be thinking about intervilus hemorrhage when you're signing these cases out. And lastly, clearly vaccination is a key to prevention of these horrific outcomes. And there's enough data to suggest it's also very safe in pregnant mothers. So it's definitely worth promoting these vaccines into the future as we face new variants. So with that, I just want to thank Dr. Drusilla Roberts, who's my close colleague and mentor on a lot of these studies that we've talked about today, and Dr. Ann Hun, one of our PGY1s who was responsible for that beautiful JAMA article. And with that, I'll take any questions.
Thank you so much, Dr. Watkins. So this was excellent, and thanks for sharing your experience with our viewers today about placental pathology in COVID-19 infection. And before we take the questions, I want to tell our viewers that the CME code is available on the chat box, so you can refer to your chat box for the CME code, and you can do both. You can either email the code to cme@coh.org, or you can text in the code to this phone number that is there on the chat box, that is 626-314-7448. But make sure that you have registered to the City of Hope CME website. So with that, I have a few questions that I saw online. So let me ask to you, Dr. Watkins. So one question that is there is about a long-term teratogenic effects on the fetus if the mother had COVID infection. Maybe you have touched it, but if you want to elaborate on that question, thank you.
Yeah, so I think it's still a major unknown. I would anticipate, just like massive perivilus fibrin deposition, as well as chronic histiocytic intervalocitis, that we're going to expect poor neurocognitive outcomes on the order of years out, potentially from the effects of SARS-CoV-2 placentitis. But because we are not yet years out from these, we haven't really had enough cases or enough reports of those negative consequences. And more importantly, even with massive perivilus fibrin deposition and chronic histiocytic intervalocitis, many babies who are exposed to those within the placenta don't actually have negative outcomes. So we may just need, almost worldwide large cohorts of SARS-CoV-2 placentitis with the children being followed for many years to really see those outcomes. But I do suspect, unfortunately, that of course, these babies were subject to a significant amount of hypoxia given the massive damage. And certainly some will have poor neurocognitive outcomes in the long run.
Thank you, Dr. Watkins. So there is another question. How do we distinguish chronic histiocytic intervalocitis related and non-related to SARS-CoV-2 on histology if in situ hybridization or immunohistochemistry is not available?
Yes, and I think that's an excellent question because truthfully, it's extremely hard. So in my experience with chronic histiocytic intervalocitis, most of the cases also show perivilus fibrin deposition. So both of those features, and frankly, can also show trophoblast necrosis. So the truth is all three features of SARS-CoV-2 placentitis can be seen in cases of chronic histiocytic intervalocitis. What can help in these cases is, one, just anecdotally, again, the cases of SARS-CoV-2 placentitis I have seen affect every single section usually, and not always, but usually of the placenta that you're grossing. So we're talking again about greater than 80% involvement, 90% involvement, certainly more than 50% involvement by these lesions. Chronic histiocytic intervalocitis can be somewhat more variable. It's usually, again, a diffuse process, but it's not always every single slide is diffusely involved. So that might be one hint, but again, there's a lot of variability there, so it's not absolute. So in any case, if you have these three features, the best thing to do would be to write it as a differential. So the first thing you could do is, if you have prior placentas from the mom, take a look back, because chronic histiocytic intervalocitis recurs. We have no reason to suspect that SARS-CoV-2 placentitis should recur in a future pregnancy. So one thing would be to compare it to priors, and if there's evidence of CHIV in a prior, then suggest that it's probably CHIV again. Alternatively, hopefully you'll have results of COVID testing for the mother, or at least a record of her symptoms at time of delivery. So if mom is displaying flu-like symptoms or had a recent COVID positive test, then you would definitely want to bring up in your differential that this could represent SARS-CoV-2 placentitis. So it's going to come down a little bit to history, as well as maternal symptoms, and working with your gynecologist, sort of putting it back on them to say, okay, this is what is here, but without IHC, I can't be 100% certain, but this is something we should think about. Lastly, I was going to mention with chronic histiocytic intervalocitis, very often there's also a history of autoimmunity in mom. So it's something else that you can look into in the history or the clinical that might help. Worst case scenario, describe the features and give the differential at the bottom. And again, just alert them that this might be something that, you know, MFM needs to follow in a future pregnancy. And honestly, if it doesn't happen again in the future, she probably had a case of SARS-CoV-2 placentitis. And if it recurs, then it's probably the CHIV.
Thank you, Dr. Watkins. So the next question is about the role of immunohistochemistry. So the markers like ACE2 and TMPRSS, are they any useful in detecting SARS-CoV-2 infection at all?
Yeah, so Drusilla Roberts led a study with Jonathan Hecht very early on basically in the pandemic, looking at the expression of those, because basically you should have ACE2 expression on the syncytial trophoblast if SARS-CoV-2 can actually enter the syncytial trophoblast. And their findings weren't very significant in that regard, and their Tempus findings weren't very significant either in their one paper on this. But with that said, to my knowledge, no one has looked at them again in placental tissues that were infected definitively with SARS-CoV-2 so cases of true SARS-CoV-2 placentitis. So it's actually potentially a very good research question. And for the moment, I wouldn't say there's any clinical utility to them.
Right. Thank you. And on the same line, there is another question that you have talked about a lot of related histologic features. Are there some features which are more specific to SARS-CoV-2 infection when someone is looking at placenta, or one has to correlate all the time with the clinical picture and all?
Yeah, again, I think the diffuseness of the situation should be one that alerts you to the possibility. And again, it's the combined nature of all three being diffusely present in the placenta that may help. And then I guess I should also add in, of course, the presence of a thrombohematoma would certainly not be something you'd be expecting with chronic histiocytic intervalocitis or massive perivilus fibrin deposition. So if you had those present as well, that should help. Otherwise, there's nothing else really terribly specific. You know, some people have mentioned, again, very early in the pandemic, that maternal vascular malperfusion, fetal vascular malperfusion might be around. But again, those are probably going to be entirely obstructed in a true case of SARS-CoV-2 placentitis, because you can't even identify those things anymore because of the massive destruction. But secondarily, you could also consider the possibility of velitis, which was something that was reported as being sometimes increased in patients early in the pandemic who were infected. And we did have a few cases with a mild chronic velitis in the background from our cohort of 7. And that's come up a couple times in literature, but again, it's never significantly more than the background population, but it's something else you could look for to sort of suggest the possibility of, again, an infectious process rather than something else, because chronic histiocytic intervalocitis explicitly shouldn't have velitis. Of course, you can have both and they can be true and unrelated.
Thank you, Dr. Watkins. I think, so these are the questions that I found online so far. And to our viewers, if you have more questions, so you can send your questions directly to Dr. Watkins, as he's available on Twitter, and you can email her, or you can also email us at Patcast. So, and we will pass on your questions to Dr. Watkins. And thank you again, Dr. Watkins, for your excellent talk, and to our viewers, thanks a lot. And Dr. Watkins, you would be happy to hear that you had a couple of hundred viewers who joined from different parts of the world, including Ecuador, Ukraine, Panama, India, Moldova, Mexico, Nigeria, Bolivia, to name a few. And thanks to our
That's
viewers.
amazing. Thanks for letting me know, Rafat. That's amazing. Thank you all for
And
your attention.
thanks to our viewers for your support, and you guys find it so interesting and informative. We find it very encouraging. And if you like our lectures, so don't forget to follow our Facebook page, that is Patcast, and you can subscribe to our YouTube channel, that is Patcast again. And we also have a website, that is pathologicast.com, where all the lectures are organized through subspecialty. And our next lecture is coming up, so that is on June 21st, and our speaker will be Dr. Elizabeth Montgomery, who is professor of pathology at Miller School of Medicine in Miami, Florida, and she will be delivering a talk on GI pathology on mesenchymal tumors. So hope to see you then. That is 21st of June 2022, and that is again at 12 p.m. Eastern Time. And thank you so much, Dr. Watkins, again, and bye.